Hello all, I am Dr. Anupama and today I would be talking about managing cataracts in corneal pathologies. So to begin with, what do you think makes a cornea complex? It could be a disease or a dystrophy, a previous surgery or trauma, or any kind of ongoing ectasia. So what could be our dilemmas in managing cataracts in such cornea? So how do we optimize the surface before proceeding with cataract surgery? What could be our intra-op facilitations to make the outcomes better? And what could be our IOL consideration in these kind of cataracts? Any post-op surprises and how to manage them? So to begin with, before analyzing any cornea, first do a stain. So a fluorescein stain will tell you the whole story sometimes. It could be as simple as a dry eye to a hidden dystrophy, something like a basement membrane dystrophy, to an ongoing viral keratitis. So whatever is the root cause of the stain, stabilize the surface first, eliminate the stain so that your biometry is optimal and the outcome is desired. So what to do in case of a viral keratitis? So what is at stake here? Make sure that there is no activity at least for 6 months before suggesting cataract surgery. Always check your corneal sensations. Try to optimize the surface for a good biometry. If there is a background uveitis, then consider antiviral prophylaxis 2 weeks before to 2 weeks after the surgery. Always perform corneal topography alongside biometry in these patients because of corneal scars. And last but not the least, slowly taper your steroids post-operatively, maybe up to 3 months. What to do if there is a stromal dystrophy? So if your dystrophy is restricted to the anterior 100 microns, then a superficial keratectomy or a phototherapeutic keratectomy prior to the surgery will give us better outcomes. Give a waiting period of 6 to 12 weeks before planning cataract if you're doing a keratectomy. Always caution the patient for recurrent corneal erosions in these eyes. So what to do if you are dealing with a cataract with a background of Fuchs endothelial dystrophy? Whatever is your procedure, phacoemulsification or SICS, it doesn't matter. But operate early is the rule. Your background corneal thickness has to be between 620 to 640 microns if you are suggesting cataract surgery alone. Use a soft shell technique, low parameters, and target a little myopic in case the eye would need an endothelial transplant later. In case of an ongoing ectasia or a background of corneal ectasia, you always determine what is the cause of change in the vision loss. We should operate only on patients whose cornea is stable. So set the patient goals realistic. Need for toric versus RGP lenses after the surgery should be emphasized. Exercise caution before implanting a very low powered lens because of the steep keratometry. Always prefer a monofocal and a 3-week contact holiday before we do the biometry. However, be ready for a risk of a hyperopic surprise. So what could be our intraoperative challenges in these kind of cornea? Always keep your positioning optimum, keep your lighting coaxial, stain your capsule with trephine blue. Also use a limbal illuminator in case the scar is a little denser. So IOL considerations, aspheric monofocal lenses are an unsaid rule in these eyes because putting complex lenses with complex optics in already compromised cornea may compound the problem. So I would like to conclude by saying that though it is quite challenging to operate in these eyes, we have to do our best to give the possible visual rehabilitation. The timing of cataract surgery is very crucial for better outcomes. It is also important to identify and manage the underlying corneal pathology so that there is no recurrence of the corneal problem after cataract surgery. A stepwise and holistic management of all the factors affecting visual acuity and quality of vision is essential for these patients. Thank you.